So we've got our keynote speaker coming up. Dr. Elizabeth Samuels. Liz is a great friend of mine and colleague I've known for a number of years. She's the right person to be talking to us right now. She's done a ton of work in harm reduction, opiate use treatment in the emergency department. She's an emergency physician. She's an advocate. She's a researcher. She previously was at Brown and partnered with the state of Rhode Island to do exactly the kinds of things that we're doing here in the state of Michigan. And so we'll come with like a lot of expertise on this topic. And I think we'll set the stage on the importance of this work from a dignity, from a humanity, from an equity perspective as well. So Liz, it's all yours. Come on up.
Oh, it's wonderful to be here. I had the opportunity to come and talk with the medic group pre-pandemic, 2018, I would say. That was a very nuts and bolts conversation about implementing an naloxone distribution program. Keith has asked me to come here and talk, set the context for ED harm reduction work and the why. Very basically, the why is that a large number of human beings are dying of totally preventable drug overdoses. I'm going to get into a little bit more of the kind of policy details and the general context for emergency department harm reduction and some of the evidence behind that. Just for some disclosures, I do have some research grants, but I have no commercial conflicts of interest to disclose. There we go. Define addiction and opioid use disorder, talk about a multi-level approach to reduce overdose deaths, describe harm reduction strategies both within and outside of the emergency department, of which there's the overall context the emergency department works within, and understand the role of emergency department leveraging and utilizing harm reduction addiction treatment services and emergency care overall for patients with opioid. So what is opioid use disorder? So just to kind of start, substance use is not the same thing as a use disorder. A use disorder is a very specific thing. And physiologic dependence on opioids is not the same thing as addiction. These are distinct categories of use. And addiction results in biochemical changes in the dopamine reward pathway in the brain. These changes produce a complex medical condition. It does involve interactions both of genetics, environment, people's life experiences, but ultimately produce behaviors that become compulsive despite harmful consequences. So you'll hear people all the time be like, they're here all the time. I don't know why they just don't stop. Everything's terrible in their life. They make the same mistake over and over and over again. And if you talk to folks, they'll say, yeah, this is not great. This is terrible, but I'm like, I can't stop. I don't know what to do, right? This is like many addictions. So we think about use disorders as having two components. One is impaired control. You impaired control of use of substance, escalating use of a specific substance, and social impairment. That use of that substance negatively affects their lives. They lose their job. They lose their relationships. They use drugs or alcohol in very dangerous situations to themselves. And separate from these two is physiologic tolerance and dependence. So you may have an individual who's on long-term prescription opioids. They have tolerance. They go through withdrawal when they stop using opioids, but they don't have these other two categories, right? They don't have impaired control of use. They don't have escalating use, and they don't have social impairment. That individual has physiologic dependence, but not the same thing as a use disorder. Does that make sense? So in the last several decades, and as I've gone through my training, we have seen escalating rates of overdose death in the United States. More than 100,000 people die annually from an opioid overdose at this point, far exceeding motor vehicle collisions. We think about it in several different waves of overdose deaths. We started seeing a rise in first prescriptions, followed by heroin overdose deaths, and with the introduction of fentanyl into the opioid supply around 2013, first in the East Coast, and now it's then moved to the West, we've seen a huge rise in overdose deaths related to synthetic opioids, primarily fentanyl. but they do not affect all communities the same. While there's overdose deaths rising overall, now the rate of increase is fastest among Black, Native American, and Hispanic communities in the United States. So it's important to look not just at overall counts, but how rate of increase is changing across the US. And underlying causes of both substance use and overdose are multifactorial, right? It may be from trauma people have experienced, socioeconomic conditions, access to services. And so our interventions do also need, as a result, need to be multifactorial. There's no one silver bullet that's going to solve the entire overdose crisis. You may be familiar with this. This is the health impact pyramid. It's a public health approach to think about interventions that will improve health outcomes for individuals and populations. So the interventions at the bottom that address socioeconomic factors, these are interventions that will have increased population health impact. And these are about institutions, environments, social determinants. And as you go up the pyramid, these are interventions that require increasing individual effort and have benefit for specific individuals. What we do in the emergency department is primarily at the top of this pyramid. So I am going to talk about some things at the bottom of the pyramid, just so you can see some of the things that are more kind of at the foundation and how it fits in. But most of our work is up here at the top. And the naloxone initiative that Mike is doing is primarily at the top. And represented a little bit differently, and I realize it's a little bit hard to read, but you can look at it later if you want. But this is a social ecological model. You may be more familiar with this in terms of thinking about interventions, that at the individual and personal level, the organizational level, the community level, and the policy. So the individual interpersonal level, this is really where the naloxone distribution fits in, as well as addiction treatment programs, syringe access programs, all the way up to policy level, which is to do with both social determinants health, but also drug policy, healthcare policies, et cetera. A little bit more simplified, we're going to talk today about downstream, midstream, and upstream interventions. So downstream interventions, like naloxone distribution, address health outcomes. Midstream, we're focused on individual social needs, and upstream interventions are about laws, policies, systems that human beings operate within and shape people's lives. So first, we're going to talk about some midstream and upstream interventions. The first is the drug supply. So as we already talked about, huge escalating rates of overdose deaths in the United States. The sharpest rise we see here is with the introduction of fentanyl into the opioid drug supply. But we're also seeing this in the stimulant drug supply. The yellow line here, it's a little bit hard to read a little bit hard to read the key here, but this yellow line are stimulant deaths involving opioids. So this is the presence of opioids, specifically fentanyl, within the stimulant supply. This is generally a community that does not use opioids, right? So they're opioid naive. And you see a sharp rise in overdose deaths as a result, which makes sense because you have no tolerance to opioids. So this has become a huge issue. People are now talking a lot about stimulant use. Do you have a lot of methamphetamine use in Michigan? Yes, we're going to talk about a couple of harm reduction interventions. And while we're talking about opioids, specifically naloxone and fentanyl test strips are very important to give out to your stimulant substance, folks who use stimulants and or primarily stimulants as well, both in terms of ensuring that they're not exposed to fentanyl, and they also may be exposed to fentanyl and unknowingly. This doesn't get to this in this graph, but you may have seen, I think a lot on the news is covered, is a lot of pressed pills, counterfeit pills, which are sold as Percocet, Vicodin, et cetera. Benzodiazepines, a lot of Xanax, for example, is actually fentanyl as well. So these kind of, especially for young people, like college age people or high school students who are, experimenting or thinking they're just getting a Xanax or getting a Percocet, are exposed to something much more potent and deadly than they otherwise have been exposed to. And many people and many advocates and people who work around drug policy to try to reduce overdose deaths directly connect the rise in presence of opioids in the stimulant supply and fentanyl in the opioid supply to the drug policy approach the U.S. has taken. So primarily, we have had a war on drugs approach to substance use. Started in 1971, we declared the war on drugs. This is a graph depicting the size of the U.S. prison population. There was a Sentencing Reform Act in 1984. These two, both the declaring of the war on drugs and Sentencing Reform Act by now President Biden, have resulted in exponential rises in the US prison population. About 1 in 5 people who are locked up for a drug-related offense. These are primarily for possession. So the orange bars are for possession, not intent to sell, just pure possession. Yellow bars are for sale, manufacture, and sell. But when we look at who is incarcerated for drug use and who uses drugs, we see very stark racial disparities and inequities. So drug use, these are data from the Brookings Institute. White folks, this is looking at white and Black individuals in the US. White folks have a little bit higher use of drugs overall, similar rates of selling drugs, but incarceration for a drug-related arrest is much, much higher for people who are Black. This really results in stark racial differences in lifetime likelihood of imprisonment in the US, both for men who are listed at the top and for women. There are some countries, and you may have heard a little bit about Portugal, that are trying to take a different approach to how we deal with addiction and substance use. In 2001, Portugal decriminalized drug possession of small amounts. It's not legal to have drugs, to be clear, in Portugal, but small amounts of drugs were decriminalized and individuals were offered treatment as opposed to incarceration. Portugal used to be kind of referred to, had the highest heroin overdose rate in Europe. It was the heroin capital of Europe. They implemented a more public health approach to addiction and overdose, and they've had some really amazing results. They've reduced problematic drug use by half. They've had a dramatic increase in individuals who are in treatment, and they've lowered their rates of incarceration due to substance use and addiction. Their overdose deaths have, so that was 1989, they decriminalized in 2001, and then these are data from 2016 and 17. They've reduced overdose deaths, HIV diagnoses due to injecting drug use, and then people incarcerated for drug offenses. And they now have one of the lowest overdose rates in Europe. And just for comparison, this is the United States rate of overdose deaths per million population among individuals who are 15 to 64. It's 216 per million people. There are decriminalization efforts in the US. We've primarily seen this with marijuana. So this is a map looking at marijuana laws in the US. The dark green are places where marijuana has been legalized, medical and decriminalized, medical use of marijuana, and then decriminalization of marijuana. Oregon in 2020, the population of that Oregon has a ballot where the general population can vote on measures. So they passed a measure called Measure 110, which kind of similar to Portugal, didn't legalize drugs, but decriminalized them. So if you got caught with possessions of small amounts, you would be either charged a fine or you could attend a treatment program. I would say what we've seen so far, the rollout of this program has not gone great because the treatment capacity did not increase at the amount of the demand. So their evaluations are still ongoing, but kind of all eyes on Oregon. This is like the first time a decriminalization with a treatment pathway for drug possession has been tried in the US. There's a few evaluations which are apparently soon to be in the peer review literature. We'll see what that looks like. All right, so that's kind of like a background context, a little bit about some policy, and I want in the larger scope, but I want to talk more specifically about patient-delivered, more downstream care we can provide in the emergency department. So harm reduction, we're using this term. What does it mean? So harm reduction is an approach to taking care of people that is focused on an individual's health and dignity, right? It really prioritizes person-centered care, involves the participant in decisions that affect their health. It recognizes inequalities and injustices people may experience or may encounter when they're trying to utilize services or in their regular life. It respects their autonomy as an individual, and it's also pragmatic and realistic. It is a non-paternalistic approach to caring for someone in the emergency department. It is, so as a resident, I used to see all the time at discharge instructions, And even I think now as an attending, stop using drugs. Like we recommend you stop using, like, right in the trash. It's like no, that is not a means necessarily like a means of engagement for people. And I do think harm reduction is not only a way I think we would all like to be treated and acknowledged in our individuality and human dignity, but is a way to engage people and bring them along in improving their health and well-being and reducing drug-related harms and hopefully getting them into treatment. So when we think about harm reduction, it's on a spectrum. There's prevention, preventing the development of a substance use disorder. There's detection of problems of a substance use disorder. And then there's reducing harms and prevention of future harms related to ongoing substance use. There's other things that we do. We don't think of these as harm reduction, but they are. Sunscreen prevents skin cancer. You tell people don't go outside ever again. You won't get skin cancer. Wearing a seatbelt or driving a car, speed limits when driving, birth control for people who are sexually active, and birth control or any kind of protection, and then filters on cigarettes if people smoke. There are a range of harm reduction services in the community as well as in the emergency department. So naloxone, we've talked a little bit about this. A big move this year, the FDA has pushed to make naloxone now over the counter. This is, or at least this one product over the counter. This is really going to change accessibility of naloxone. Opioid overdoses deaths are preventable with prompt administration of naloxone. That is the spirit in which naloxone saturation relies on. If you are not near someone with naloxone and you've had an opioid overdose, it is very difficult to reverse that overdose, but they are preventable with prompt, timely administration. Syringe services programs, which I'll talk a little bit about briefly. These are evidence-based interventions to reduce injection-related infections and promote engagement. Fentanyl test strips, which I don't know if how widely those are known about or distributed in Michigan, but these are ways people can test the drugs they use for presence of fentanyl. I will say a caution about these: they do not test all analogs. So it's the counseling I think is complicated because if it's positive, you can be sure that there's fentanyl in it. But if it's negative, you're not really 100% sure there's fentanyl in it because it does collect most analogs. But again, there's the folks selling drugs keep adjusting that side chain just a little bit, and some of them will get missed on these. Overdose prevention centers, which I'll talk about, and then many advocates are now really talking about safe supply, which our neighbors in Canada are doing some more work around. They're the primary country doing work around that internationally. So community naloxone distribution has been happening since the 90s. Started in Chicago by Dan Fig. He's kind of the first person to distribute community naloxone, and many harm reduction programs, I would say all harm reduction programs, such as community-based naloxone and naloxone distribution generally owe a debt to this individual for pioneering not only community naloxone distribution, but saying that people who use drugs and their family members can reliably give each other naloxone to save each other's lives. And he's unfortunately now passed, but all of the work that we're going to talk about today is based off of his initial work. I think one of the things it's important to kind of underscore when we think about naloxone and why we give it out. You cannot get to treatment if you're dead. That is not a possibility. And naloxone distribution, use of naloxone gives people an opportunity to engage in treatment. Opioid use disorder is a chronic relapsing condition. That's what we talk about it as. It is something that people manage for often a lifetime, depending on the individual and the severity of their opioid use disorder. And it really gives people an opportunity, a second chance, or sometimes multiple chances. But that is, I think, kind of like the underlying spirit. Each of these individuals is someone's sister, brother, mother, cousin, etc. We have seen lay people can reliably administer naloxone in the event of an opioid overdose successfully. And evaluations of community naloxone distribution have both seen that people who attend or receive overdose education and naloxone distribution Both have an increased engagement in treatment and reductions in substance use, but also reductions in overdose deaths, and it's shown to be cost effective. Certain services programs, very briefly, no, we're not really talking about this today. And there are only a very few emergency departments in the US who are providing sterile consumption supplies. But syringe services programs provide sterile consumption equipment to individuals. They also provide like overall drug user health. So they'll provide Hep C testing, HIV testing. A lot of them will provide addiction treatment initiation, naloxone, counseling. Individuals who engage with a syringe services program are about 5 times more likely to enter addiction treatment. It both reduces HIV and hepatitis C incidence, reductions in crime and engagements in law enforcement, and reductions in public litter of drug consumption equipment. This is a map looking at legality of syringe services programs. Now, so these are recommended by both the CDC and the World Health Organization as an essential health service. The red states are states where syringe services programs are illegal. The dark blue states are where syringe services programs are legal. And then the kind of this lighter faded blue, which includes Michigan, are where syringe services programs are locally permitted, or there's not really a law addressing it. There's some places where you can get like individual permission. There's a lot of modeling studies. If you're interested, I'm happy to send them to you, which looked at HIV incidence prevention with establishment of syringe services programs. West Virginia and Ohio being the primary states have had a very large outbreaks of HIV related to shared injection equipment. And some challenges to their syringe services. So overdose prevention centers, you may have seen this in the news, primarily in New York City, as well as in Rhode Island. What an overdose prevention center is a place where individuals can use previously obtained drugs. There's over 120 of them in 10 countries. There's a wide variety of models. There's medically or peer supervised ones, so you may have a supervised consumption center on the ground floor and an inpatient addiction treatment upstairs. It's staffed by physicians and nurses. You may have a more peer-based stationary mobile units. There's a wide variety of models. All of them are integrated with existing services and provide linkage to services, and they're very heavily researched. I'm happy to give you a list of citations, but overall, the evidence around these overdose prevention centers have shown increased treatment engagement, increased safe use practices. They are cost effective, particularly from both overdose and HIV incidence level. They're feasible and acceptable. And then there's increases in medical and other services utilization. They're associated with reduced overdose deaths, all-cause mortality, injection-related harms, syringe reuse and sharing, public drug use and related litter, and crime incidents at sites. There was an unsanctioned center in an undisclosed city, now closed. But they have published several evaluations of that study, which showed no overdose deaths, reduced crime, emergency department visits, and hospitalizations among people who utilize the center. Philadelphia was one of the first ones that tried to open in the US. They are in a legal battle through federal court. Both the federal district court initially allowed them to open, and then now there's been a reversal of that decision. Now they're back in court. New York City has 2 centers currently operating under a peer model and a medical model, supported by the Department of Health there. Rhode Island passed a law allowing a pilot center. Before I moved to California, I was very involved in the regulation process for that. So there's like a state regulation about what those programs will look like, and their state is set to open this coming year. And there's some other jurisdictions who are also considering. So addiction treatment, and just very briefly about addiction treatment, there are 3 FDA-approved medications for opioid use disorder: methadone, buprenorphine, and naltrexone. Methadone is a full agonist. Buprenorphine is what we call a partial agonist, and naltrexone is an antagonist. It completely blocks the opioid receptor. Medications for opioid use disorder are associated with or have been shown to improve survival, treatment retention, ability to gain and maintain employment, and improve birth outcomes among people who are pregnant, as well as newborns, and reductions in overdose, mortality, HIV and hepatitis C infections, and involvement with the criminal justice system. They, in addition to, this is a study looking at reductions in overdose and acute care utilization. That's us in the emergency department. Buprenorphine and methadone are this top line, which looks at reduced opioid overdose, and the top line here, which looks at acute care utilization. In terms of mortality, this among emergency department patients who had a non-fatal opioid overdose, who got medication for opioid use disorder in the year following their ED visit for opioid overdose, specifically for methadone and buprenorphine, we both at 1 year saw reductions in all-cause mortality and opioid-related mortality. So this study here kind of underscores, whether it's starting treatment at the time of the ED visit or linking them to care, you do have a direct effect on someone's mortality and risk of death after their ED, which is incredibly high. And overall, medication for opioid use disorder reduces the risk of death. So addiction treatment, it works, it saves lives. It should be happening everywhere. It is not. It is very far from happening everywhere. A minority of people with a substance use disorder are engaged in treatment, and that is for a variety of reasons. So there are many different barriers to treatment access. Some of them are based about individual characteristics. Some of them are about where people live, what type of insurance they have, what their income is, and then what addiction treatment is available to them as these all affect what treatment is available to them as an individual, and then what type of medication they may be able to access. So again, the barriers: cost, insurance, transportation, stigma, both about the treatment or stigma they may encounter within the healthcare system, their knowledge. There's a lot of very stringent treatment requirements which people often cannot meet, and there's a really limited provider availability. So this is a map looking at county level capacity to provide buprenorphine, so just one treatment type. Obviously, as you know, there's many treatment types. So we see a huge geographic differences in county level ability to provide. The darker green are higher number of facilities per 100,000 population, and rural communities are some of the most impacted in terms of having limited treatment access. In terms of provision of linkage to care for people after an ED visit for opioid overdose, we see significant differences based off of gender, age, and race. This is a study in a commercially insured population, so insurance should not have been a problem for this group of people. And what they ultimately found is that white individuals were much more likely to get referred for follow-up care. Men were much more likely to get referred for follow-up care, and younger people were much more likely to get follow-up care. Overall, kind of taken some of the context around criminalization, which we talked about before, and some of the treatment inequities. When we look at Black individuals and white people, Black people are much more likely than white people to be arrested for a drug-related charge, have longer sentencing, and be in prison for drug-related charges, but they are much less likely to be initiated on medication for opioid use disorder, engage in treatment after an ED visit for overdose, and receive behavioral counseling after an ED visit for opioid overdose. And so this really underscores what we're doing and how we do it. Obviously, anyone we take care of deserves high standard evidence-based care, but this is a really important racial equity issue, and it is something that we need to keep track of as we're looking at the quality of the care we provide. The emergency department care. Am I doing okay on time? Okay. So this is a little bit old data at this point, and this is from 2018. But we're seeing, as you know, rising ED visits for opioid overdoses. You've been seeing this for almost the last decade. Mortality of a person that we see for an overdose is incredibly high. So I'll get called to triage or like to ambulance waiting, and they'll say, Liz, this person just came in for an overdose. They want to leave. They're awake. They're breathing. They're fine. We don't need to do anything else. Like, they can just go. Can you just clear them? And the risk of these individuals after an ED visit for an opioid overdose is much higher than most people we see in the emergency department. So the risk of death in 1 month is 1%, but 1 in 20 will die within a year. So the number of times I review with a resident what someone's heart score is, and I admit a low risk chest pain or medium risk chest pain, and this other person just is going out the door, they have a much higher risk of death. So it's 4 times higher the risk of MI or death in patients with moderate risk chest pain, and 2 times risk of MI or death in patients with high risk chest pain. We should put a lot of resources into people with moderate and high risk chest pain. That's not what I'm saying. But even those people are just just come to ambulance, they can go out the door. There are some things we can provide them, even if it's a quick little thing, maybe it's not a long engagement, to try to affect their risk of death. Because we have a very specific role, right? So we provide time-sensitive treatment and stabilization. So that may be the immediate reversal of an overdose death. We're an acute diagnostic center, and we provide healthcare access and treatment linkage. So like if you break your bone, we connect you to ortho. If you're newly pregnant, we connect you to OB. If you have a substance use disorder, we should be able to connect you to treatment. And so the 3 kind of general areas that fall within our wheelhouse, and they don't need to be long and involved and time intensive, are about prevention, harm reduction, and treatment, either initiation plus minus linkage. This is maybe a little hard to read, so I apologize, but this is what we call a learning health system. So kind of how clinical research informs policy, policy informs clinical practice informs policy, and then identifies our clinical research questions. So as you are in this quality collaborative, so quality collab and quality measurement, quality improvement informs all of these things, right? So you're in a quality collaborative. Quality collaborative now is like seeking to improve naloxone distribution. That's sort of this is somewhat informed by policy. Like ASAP has a clinical policy around eating naloxone distribution. That's going to change some of the clinical practice. You'll reflect on in your clinical practice what works, what doesn't work, what's better, how do we make it better, and that will define some research questions which may affect and change what quality measurements and quality improvement initiatives that Medic takes on. So how do we assess patients? How do we engage patients? This is often very hard because I think that for multiple reasons. One, we are usually engaging people when they are not the best version of themselves. All right, that's putting it mildly at times. And I think it's important to keep that in mind. What is going on with them has nothing to do with you. And you also cannot make them do anything they want to do. They've often had a lot of really bad and negative experiences in the healthcare system, and you are inheriting all of those prior experiences, and it can feel, and in the moment, like is directed at you. So I think it's important to kind of separate that out when you're engaging a person and like really focus on, and not everyone is willing to is at a point where they're going to have a conversation about what's going to motivate them to change, right? But this is the kind of underlying principles that I try to improve my chances of engaging with an individual. Maybe immediately after an overdose, or maybe they present and they are ready to engage in treatment. They're in withdrawal. They want treatment that day. But leading with empathy, not arguing with an individual that will really shut down the relationship and damage your therapeutic alliance with the individual, and seeing where they are in this stage of both willingness and confidence and readiness to engage in treatment. And our job is really just to meet people where they are. Sometimes, I think we like the very clear wins, right? It's like we started a person on treatment today, they're going to treatment, and like you feel like you won, and like that is successful, right? But our job most of the time is just keeping the door open. Like when you are ready, we are here, we will help you, we can start you on care, and we can get you on to the next step. And there's like multiple levels, right? So some of this is about psychosocial support if you have those resources in your ER, which many ERs don't. They're about behavioral health. I realize you can't see the bottom. I don't know why I said that. But the bottom is the social determinants of health. And then providing medications for withdrawal addiction treatment. A quick word about medications for withdrawal and addiction treatment. I do sometimes, or often, when I sense that someone who's in withdrawal, but they're maybe unsure about medications, I will talk to them about, it can be overwhelming to them to think that they're making a forever decision. We have tools and resources that can help them feel better so they can more successfully engage in treatment. So I try to break that down a little bit and say, like, this is a decision for today. You do not need to feel ill. We can start you on, let's say, I mostly use buprenorphine in the emergency department. We can start you on medication, and we'll link you to treatment, and you can make other decisions later. but it's hard to make a decision when you feel like you have the flu, which is what opioid withdrawal generally people experience it as. So what we provide in the ER, naloxone distribution for overdose rescue, behavioral counseling, if your hospital has that type of capacity, medications for withdrawal and addiction treatment. This is just buprenorphine, but some EDs are doing methadone, and then linkage to care, follow-up care. So emergency department naloxone distribution provides naloxone, puts it in the hands of people who need it most. It promotes patient engagement. It can be even just a means for conversation and expression of care. It really does demonstrate that you think that their life is inherently worthwhile. And I will tell you that most people who use drugs do not, despite whatever conversation you might have with them, they do not feel like their own life is worthwhile. They're in a not great place. And that can really help build relationships, therapeutic alliance, and trust, and is an entry point to conversation. A lot of times people will say, well, I don't need it. So I say, you might not need it, but I don't know what the rate is here, but in Rhode Island, 1/3 of overdoses were in public. So it's like, you might not need it, but you might come across someone that does. So, and I mean, there's like a little bit of maybe dissonance there for that person of like whether they think they actually need it or not. Again, naloxone saturation is really important. Overdoses cannot be reversed if naloxone. I'm just going to very briefly go through these, but emergency department naloxone distribution is feasible. There have been multiple studies that have looked at this. People will utilize it over time. This is from Rhode Island. And there is an ACEP clinical policy advising for distribution of naloxone in the ED. Just a quick word about direct distribution with a kit versus prescriptions. There have been multiple studies that have looked at this. People don't fill a prescription. They're not going to go to the pharmacy. Having the direct kit is the best way to get it in the. All right. There are many, you're going to go over this in more detail this afternoon, but there are many factors influencing emergency department naloxone implementation and provision. The strength and knowledge of the research evidence, state and local laws. There are many laws guiding this ability to distribute naloxone, especially directly to patients, emergency department, hospital policies and procedures, professional organizations, cost and payment mechanisms, provider attitudes and willingness, and then patient reception. In terms of improving treatment and services linkage, there are several things that can help with follow-up for both addiction, either referral to addiction treatment programs or harm reduction services. So there is this kind of online atlas, which provides some information about local treatment programs. Some cities and states have treatment dashboards. Building your own local referrals and relationships can be really helpful to leverage. And then telehealth. We started a statewide low threshold telehealth buprenorphine treatment program during COVID, which has continued and provides a lot of backup to emergency departments that can help also provide navigation and linkage. Medication costs in terms of buprenorphine, there is GoodRx. There are a lot of coupons, and there's some drug manufacturer coupons. And I'm going to talk very briefly around health-related social needs, individual support, and navigation. People have a hard time getting to treatment and having the both transportation assistance and peer support, or community health worker, social work support, if your emergency department has that, can be really helpful. These are programs that use a strength-based support approach, provide linkage to treatment, guided mentor, resource navigation. They're very heterogeneous. You've seen one program. And there is a lot of research ongoing about them. This is our program that I helped start when I was at Brown. These are 3 of our community health worker peers. This is an emergency department-based program. They're both community health worker peer recovery specialists. They provide engagement at the time of the ED visit and short-term case management. And they provide initiation, provision of harm reduction, addiction treatment, and help with health-related social needs. This was the first year, 2001-22. They approached about 700, a little over 700 people. 64% accepted services. About 120 of them did short-term case management, just about 3 months, and then provided just one-touch encounters at the time of the ED visit. About over 80% were engaged in addiction treatment who received a community health worker. About 3/4 were linked to harm reduction organizations, and just under half were provided. And some of our initial data around this program is that we've reduced emergency department visits, 1.8 fewer ED visits per year, 1.3 fewer hospital admissions, and then 7.8 fewer days in the hospital. We've also had lower left without being seen rates, which was good, especially in the context of COVID, which had overall increase in left without being seen. So just to summarize what we talked a little bit about today, downstream interventions, which really focus on individual health outcomes. This is where our harm reduction initiatives lie, ED buprenorphine and or methadone, treatment linkage. Midstream interventions are ED community health worker peer interventions or emergency department community initiatives. And then the upstream interventions, these are the large population health impacts or drug, social, and economic policies. So I know that was a fire hose of information, but just to summarize, addictions are complex biopsychosocial conditions. Upstream policy changes will have the largest public health impact, but what you do in the emergency department does matter. There are multiple evidence-based interventions which we have shown to be feasible and work. You all are taking on a really important one of those, which is naloxone distribution. And I'm happy to take any questions and excited to. That is a good question. I don't know. I don't personally have data about that. I think some of that is us for two reasons. One, it's hard to reflect on retrospectively in the chart, but totally possible through an extracted chart review. I will say our AMAs are actually, at least the ones I'm new in California, so I can't speak to that, but our ones in Rhode Island were pretty low. And typically when people get discharged from the ambulance bay, we sign those folks out AMA. I think that there's two strategies which I think are helpful. I think one is, and what has been really helpful for us is once we started with the community health workers or social workers, they actually lead and engage a lot better than we do. Like even I think I'm really nice, right? And I'm like, I got it, like I'm really nice. And I'm empathetic and all those things. But they're like, you're a doctor, like I don't want to talk. Like and I'm like, okay, like I am worried about you, like, da 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 da, like you heard breathing today, all the things, right? But like the peers are really helpful because they can level and relate to them and are approachable, and the power differential is really different. But that's like, that's a resource program. So it is a bit different, but they can like de-escalate and talk people down and engage them in like a really meaningful way. And I think like I am able to do that portion of the time, but there's a lot of times when you just can't. And so, I mean, I think that, okay, one thing I would say, there is a couple programs that do this on their naloxone. They actually have the phone number for the addiction treatment program, like they tape on the actual naloxone itself. So they made a lot of papers get lost, right? But even just saying like, okay, expressing the concern for them, they may not stay. And I don't know if staying actually, honestly, like is or isn't the measure of success there, right? I think you need to follow people longitudinally to see what happens afterwards. I mean, staying, I think, would be beneficial if they want to engage in services then. But a lot of times, or at least what we found with our programs in Rhode Island, people take a couple days and then they'll actually call the program back and say, like, I was in the ED for an overdose 2 days ago. I really wasn't ready to talk to anybody, but now I want help. And they kind of reflected on whatever went on, talked to their friends or whatever, and then they would engage with our outpatient community-based services provider. So there's something about those 48 hours. Like, I think it is meaningful and worthwhile to do the ED engagement. Obviously, when we're talking about it, I didn't. But I think that there's engagement after the ED visit, which isn't salient to us. We don't always see it. But our community partners have really said, like, they didn't want to see or talk to you then, but they come back, they got our information and they reached out to us afterwards once they've kind of had time to reflect on it. Our peer programs in Rhode Island were not specifically ED based. We partnered with a community based recovery organization, and they had two components of that organization. One, they were on call for all the EDs in Rhode Island. They just had a relationship with them. But then they also had a team that would, if they knew someone was in the ED specifically for repeated overdoses, they had a street outreach team which would go find that person. and like try to engage them with the peer recovery center, which I thought was really excellent because most people don't have working phones. Some people do, less so at the end of the month, you know, but they would know where people would hang out and where they would be. You could try to find someone, but that kind of community relationship with a community-based organization is really useful, both because it may be an organization that people trust and like, or will be able to trust and like, and doesn't require investment on part of the hospital, for places that maybe are, you know, lower resourced or aren't able to staff an ED-based program or something like that. So in terms of, so one thing is in terms of billing, it depends, a little bit depends on the state. So some states, you can bill for, depending on what your workforce is like. Some states have instituted billable hours for peers, billable hours for community health workers, and billable hours or billable procedure codes for like brief negotiated interviewing, basically. So that is in the program. When we started the program at the SMART program, it was a Department of Health contract I had through my medical directorship there, but the hospital took it over and they are going to be doing billing through those other means. I think the hospital also, and we talked to different insurers as well for their specific, you know, cohorts of patients. The reductions in utilization were also, I think, for them meaningful enough, particularly days in the hospital, because a lot of times people will be in the hospital and they have nowhere to go, particularly if they're on like antibiotics or like for long term for like an infection or something like that. Like their ability to get housing and placement or SNF placement where they can have like ongoing services reduces overall hospital costs. So they looked at that as like a financial benefit to them too, in terms of like speaking with the hospital administration to hire them in a, you know, more sustainable fashion. I do think there will be more federal level billing abilities. I think that a lot of it is really state by state. I mean, I think it's not going to be one thing. I think it's multimodal. I think there's I think there's a policy side around criminal justice and like drug policy side, right? But in terms of our wheelhouse, like the healthcare system and what we do, I think protocolized care is really helpful at, you know, dealing with treatment equity issues. So like from the emergency department, if you have increased referral to treatment among white male patients, but you have a protocol that you implement uniformly for all of your patients with a substance use disorder and a quality measure around provision of that protocol, and we've seen this with other health conditions, right? You can really, I think, decrease that gap. But there are these other structural determinants outside of like the protocol you provide in the ED, which influence whether people provide care. This was one of, like, I think, the driving motivations behind our community health worker program, and why some of those do some short-term navigation is because some people, they need more help getting to the appointment, and that might be it's usually transportation and housing, to be honest, in terms of like what the main barrier is for them or what they're navigating that is limiting their ability to engage in services. Because Rhode Island is insanely insured, like 97% of the general population is insured. It is not an insurance problem and the inequities in Rhode Island. And even in the other thing I would say is, so I said that there was a racial inequity in behavioral counseling. That's actually a study from our ED. We have a protocolized care system where there's an order set, everyone utilizes the order set, they get an email about whether or not they use the order set, like all the things. But I think some of that initially was who was engaging. So when, you know, when we hired our community health worker peers, we were very intentional about who we hired. But that was complex. We had hired a largely workforce of color into a largely like nursing and physician workforce, which was white, which created a whole other barrier, like implementation issues of racism and staffing and in the emergency department. But that's probably more in the weeds than you needed to know, and like then that needs to be, you know, addressed as well. Because the healthcare system, you know, I think there's a lot of stigma, a lot of discrimination, a lot of bias that needs to be addressed kind of overall, so people feel comfortable, safe, receiving services and accessing care. Something we cannot control in the emergency department is like competency of the outpatient places we refer to. Is there linguistic access? Do they have interpreters? That's a huge issue. A lot of places don't have interpreter services. If you don't speak the language of the patient you're trying to refer, you're not going to be able to receive services. So it's a really multi-layered issue at many different components. There are some things we can control in the ED itself, but other parts of the system also need to work for greater equity and accessibility. I don't know if that answered your question. Yeah. Yeah. So there isn't data about morbidity and mortality, but there is about use behaviors. So there's a few studies that have been out for maybe like 4 or 5 years, and then there's a randomized controlled trial finishing up now, and which showed that the ones that are already published looked at people who use fentanyl test strips. Do they modify the use? And the answer is yes. They'll either not use or use less, or not, and also to add to that, not use alone. So they did show that people modified their behaviors. That's in people who use opioids, though. I haven't seen a similar paper about people who use stimulants who then test their drugs. So there isn't data about morbidity and mortality, but there is about use behaviors. So there's a few studies that have been out for maybe like 4 or 5 years, and then there's a randomized controlled trial finishing up now, and which showed that the ones that are already published looked at people who use fentanyl test strips. Do they modify the use? And the answer is yes. They'll either not use or use less, or not, and also to add to that, not use alone. So they did show that people modified their behaviors. That's in people who use opioids, though. I haven't seen a similar paper about people who use stimulants who then test their drugs, but I think full disclosure, I think they're most useful. Like in my non-research self, things are most useful for people who use stimulants. And that's partially coming from the fact that, like, having been working in Rhode Island, everything is fentanyl. Like everyone who uses opioids, unless you're using pills, people just assume it's fentanyl at this point. That's different in California. So in California, fentanyl's recently arrived there. So I think there is more utility for fentanyl test strips there because people don't have a tolerance and aren't used to using it, and it's then like more potent and more deadly. And that's, I think, its utility is really among people who don't have tolerance or will unknowingly be exposed to fentanyl. But there is a whole group of people, like the folks who will experiment and take a pill and take whatever. Those individuals, the fentanyl test strips are not even on their radar because they don't regularly use drugs. They don't have any tolerance. That's a little bit of a different population as well. So then there's not really data on that population. But I'll tell you what I think for whatever it's worth. I think the best Narcan kit is the one someone takes. So, I do think that, there's amazing kits out there. They're like in a little pouch and it's zippers and there's like, whatever. There's multiple things in there, like for folks to reduce drug-related harms. I'll tell you, the kits we give out in Rhode Island, we just give them a box and numbers of like on it, like of who to call, et cetera, et cetera. And I initially was kind of embarrassed. I was like, oh, our kits are so bad. But then I was talking to people and they were like, well, I don't want a big bulky thing. So I think, but also some people are like, I would really love all of those resources. So it may be different. I didn't answer your question at all, but that's what I should think. Yeah. So part of that is because the heroin in California is black tar heroin. It was like not, on the East Coast was powder, although it is introduced now. And anyway, it's there now. So that and some of it was like how, I guess, the drug trafficking routes are. But at least in Rhode Island, so fentanyl is very different, and then heroin. It is very short acting, so people will use multiple times a day. But as you have heard, it's also very lipophilic. So it has this kind of kind of like hangs around and is like available, but they're not high from it at the same time. So you'll like have someone like in a lot of withdrawal, and then but they still have like fentanyl around. It's a little bit complicated. There's a lot of things we don't know. There are some interesting things coming out around, particularly around fentanyl overdoses, that there's this like amnestic quality. There's like kind of like a neurotoxin component to it, which is really different than heroin as well. And I've taken care of some people who you'll have like different kinds of memory problems that they like you don't see in other folks with long-term opioid use. And we had a few cases in Rhode Island. There's a researcher in Massachusetts and one at Yale that's they look at all these MRIs of people who have like different kind of damage to their different components of their brain, actually. Some of the memory centers, some the optic nerve that they think is related to fentanyl toxicity. I don't know that we have like a lot of data around long-term use effects. I mean, I do think it's very different, so like there was an article, and I think it was in the Washington Post. There was a huge spike in overdose deaths in the Black community in Washington, D.C. among people who used heroin for a very long time with the introduction of fentanyl. It is in generally more potent, and the overdose risk profile is much higher. So I think that, even in folks who are long-term users of fentanyl, I think we'll see, higher mortality, even if they have tolerance to it. But treatment initiation is sometimes more complicated. I mean, I think it's a myth that you can't start someone on buprenorphine who uses fentanyl. I do it all the time in the ED, on the phone, etc., safely. I think there's a little bit to figure out about, there is a profile of a person who's more likely to precipitate. I don't think we've totally figured out all the characteristics of that. But I think, especially folks who co-use stimulants, that can be a little bit challenging. And there's increasing rates of that. So it's all a little bit complex. I also didn't answer your question, but those are some of my thoughts. So I feel like a little bit privileged to have done this in Rhode Island, just because the rates of deaths were so high there. Most people knew someone with a substance use disorder who had had an overdose or who had had an overdose, particularly in the legislature. A bunch of people had lost kids. So I think that really enabled, a lot of the humanizing conversations. Just because I think there's like this othering of like, those addicts, they're just terrible and they're ruining all the things. I think one of the things we've done, this is like maybe like larger system, is like having people in recovery working in the emergency department. And people really, because we only see people when they're not doing well. We don't get the benefit of seeing people do well. People do recover. People do engage in treatment. People do live fulfilling, self-determining, happy, productive lives, right? I think that people forget that or lose sight of that, or think that's not something that happens. And I think that really shapes and influences their attitude towards someone. So, I do think, to me, trying to relay to someone the humanity of an individual, or even just I think changing what the expectation might be of we are for this person's long-term outcome. We may not see them every part along the way, but we know a lot of people who recover. One of the things I do, sorry, this is like a sidetrack, this may be like a larger thing. I do especially if we were doing a clinical trial of ED buprenorphine, when people follow up in treatment, or even when they don't, but email the treating team and let them know the person's outcome. I think that's a really important thing for ED clinicians, because we send referrals for things all the time, but letting them know when people do well, they followed up in treatment, thank you so much, you did a great job, or feeding back to them those types of numbers and things like that can help them kind of see oh, that wasn't just a throwaway thing I did, that we actually were effective, and what happened next. Because we don't really, again, I think, not most of my colleagues don't have the benefit I've had, working on the buprenorphine hotline. it's like one of the most rewarding things to do addiction care. It's like people are scared, they don't want to die, they're like grateful and like just so happy to have someone help them. That's not the engagement we get in the ED, right? I feel like in the ED, I'm just like, please tell me start your treatment. And then on the phone, they're just like, thank you, God, you're there. And I'm like, it's very different, right? But they're mutually enforcing. Most people don't have that experience. So I think the one thing that helped me when we were first starting our naloxone program, I guess in 2014, was just really underscoring like everyone gets a chance to engage in treatment. These programs have not been shown to increase use. And again, it sounds callous or whatever, but you can't get to treatment if you're dead. And like, I want them all to have an opportunity to do that. This is someone's family member. Someone cares about this person. And like, they deserve to have that opportunity. So, and like I had a more shorter way of talking about it. And then you can show them lots of data if they want that. Because there is a lot of it.